Great. I'll start. I've started recording now.
Okay. All right. Hi, everybody. So I just want to start. Well, today I'm going to talk to you about lung ultrasound and pleural abnormalities. And I've just sort of titled it a bit of a caveat, a deep dive, sort of, because this turned out to be a much more complicated topic than I expected it to be. So most of you know me by now. I'm Jake Donovan, local MICA paramedic and PhD candidate with Monash University, looking into ultrasound utility for paramedics in the out-of-hospital setting. So just start with some objectives. We're going to cover a few things. I just want to start by saying there's a few things I'm not going to cover today. So I sort of assumed that most of you would have some basic, if not advanced, knowledge of lung ultrasound. I'm not going to cover lung sliding or pleural effusions. I figure that kind of stuff's been done to death and you're very familiar with it. So we'll start by covering just some really basic overview of the anatomy, physiology, and physics, just the core concepts that are relevant to today's talk. So that's going to be very short and to the point, and hopefully won't be telling any of you how to suck eggs. We're going to talk about lung ultrasound, how and why, so which probes to use, which protocol, if any, to use, how many scanning points should you use, topics like that. And then I'm going to really focus in on B lines, and a couple of other artifacts will be mentioned, but as I said, no lung sliding, no pleural effusion. I'm going to really focus in on pleural line abnormalities and consolidation. And again, I've sort of titled this a medium dive because I went down a real rabbit hole of trying to understand this stuff. And as you'll come to learn, it's not overly clear in the literature, but we'll get to that. All right, so as I said, really basic overview of the anatomy and physiology. You've all been to medical school, so I'm sure your understanding of this is excellent. And I'm not going to teach you how to suck eggs. Start with the pleura. So we've got our layers of pleura, visceral and parietal. They're sort of challenging to differentiate on ultrasound, but apparently with a really high frequency probe, it is possible. But there doesn't seem to be a great deal of value in doing that. And for most of us, it's just going to appear as a single white line, measuring about 0.2 to 0.3 millimeters. So if you're inclined to measure it, you could say if it's thickened or not. But again, there's not a great deal of value in doing that as far as I'm able to determine. So the other thing I really want to focus in on is this idea of these small sort of surface lung lobes and the interlobulus septa, which is highly relevant when we're talking about B lines and consolidation. But for now, just a quick refresher on what it is. So a thin wall of connective tissue separating these adjacent pulmonary lobes, encapsulating a number of alveoli, containing sort of lymphatic vessels and capillary beds and stuff like that, and also providing structural support to the lung. So just a quick physics topic here. Again, this is the most basic physics stuff, but just a quick overview. As for me, I found ultrasound physics to be wildly complicated. I prefer to think of it as magic. But air is a very strong reflector of sound, and generally speaking, 99 point something % of sound waves are reflected back to the probe. And I like to think about the lung as being sort of an unbroken barrier of air under normal circumstances. And when it is broken, that's when we're able to see the pathology. All right. So a quick overview of the artifact. So we've got our A lines, a horizontal reverberation artifact. You see your pleural line, and then you'll see reflections that slowly get fainter as they travel towards the bottom of the screen. And you can use A lines as a bit of a guide as to whether your angle of insonation is ideal. So if you've got that true perpendicular angle, you will see the A lines more clearly as to whether you're not on a clear angle. B lines, we're going to talk a lot about this today, but the official definition is laser-like vertical ring down artifact extending to the bottom of the screen. And then Z lines, a vertical artifact similar to a B line in appearance, but doesn't extend to the bottom of the screen. And no one seems to think that there's any pathological basis for Z lines or understand particularly why they exist. So put them aside. Other than differentiating them from B lines, we don't need to know anything about them. So let's talk a little bit about lung ultrasound. I found in my sort of journey of learning about lung ultrasound, and you know, I've been doing it for a couple of years. I've published a few studies on it. It's definitely within my realm of interest. One of the hardest things about learning it is that there's no standardized protocol across the board that people are using in emergency medicine or intensive care or out of hospital. And there's no consensus on what, if any, protocol should be the standard. So when you go to learn something like AAA or EFAST, it's very set, it's very formalized that these are the views you're trying to get. Sometimes even this is the order in which you get them. This is the probe that you use. But with lung ultrasound, you know, you've got protocols ranging from 4 points on the anterior chest all the way to comprehensive 72-point lung ultrasounds, which I can only imagine would take an obscene amount of time to do. So this is a question which comes up a lot in lung ultrasound, and I think a very relevant one. So we'll talk a little bit about that. So I've just chosen sort of 4 protocols that I've come across that are sort of the more commonly used ones to just discuss. I'm not going to go into them in great detail, but just to give you an awareness that they do exist and which ones might be ones that you'd consider using in your practice. So we'll start with the blue protocol, which is bedside lung ultrasound in emergencies. The original lung ultrasound protocol developed by Dr. Lichtenstein. It's 6 points, so 2 anterior points on the chest and the posterolateral point, which is called in the protocol the PLAPS point, looking for pleural effusions and consolidation at the bases. And essentially what the blue protocol does, which I really like, it's nice and simple, which is great for paramedics. It's exactly what I like in terms of my own practice. It takes these groups of lung ultrasound artifacts and puts them into lung profiles, which then equal a diagnosis. And again, I'm not going to go into the protocol in any great detail, but what I really liked was that when developing this protocol, they tried to make something that was sort of a mix between diagnostic accuracy, simplicity, and efficiency. So the protocol is not designed to pick up 100% of pathologies 100% of the time. It's really designed to pick up the most common pathologies you'll come across when scanning a chest. And it's designed to have a 90% accuracy for all of those things. And unlike the other protocols that we're going to talk about today, it only has one non-lung scanning point. So it does ask you to look for DVTs if you've got sort of a normal looking lung and a shorter breath patient. But you know, you can leave that step out if you're not trained to do that and still use it for the most common findings. So that's probably the most common one. It's the one I use mostly in my own practice, and it's a great option. Next one I'll talk about is the 8-point Volpicelli one, which is sort of a more common one that you come across in the literature. You can see the diagram for it in the top right image of the screen there. So sort of 4 scanning points per side of the chest. And it's one that comes up a lot in the literature as just a general approach to lung ultrasound. Unlike the blue protocol, it doesn't go into specifically grouping artifacts together, but rather just gives you an approach to how you should start scanning. And then you interpret the findings based on your own clinical judgment. The CLUE protocol is the COVID lung ultrasound in emergency department protocol. And I think COVID has been the best thing that ever happened to lung ultrasound. It's not good for much else, but it's certainly exploded lung ultrasound research throughout the world. And this is one of the main protocols to come out of that. And essentially, it takes a really different approach to scanning the chest, which I would like you guys to consider, and I'm interested in your comments afterwards. But generally speaking, when you're doing lung ultrasound, you pick a point on the chest, you sort of line up your ribs so that you've got your nice, neat pleural line in the middle of the screen, and then you take a clip, and that's your one point, and then you move to the next point. The CLUE protocol sweeps. Instead of scanning an individual point, it involves a sweep through the entire thorax, basically, where you start at, let's say, the first intercostal space, you sweep across the chest, and you go down, then you sweep across the other way, down. And so essentially you're assessing every intercostal space on the lung, but you're not taking static clips. You're sweeping to look for pathology, and then if you find something, you then take a clip of it. And it's got a scoring system for the severity of COVID-19. I think it's probably a little bit more time consuming than some of the other protocols, but provides a really thorough look across the whole chest, which is quite an interesting one. And then finally, I just wanted to talk about this 12-point scanning protocol. And I haven't put it up on the screen anywhere, but there was a really interesting study that a group of authors did where they compared the accuracy of different scanning protocols based on the number of scanning points versus CT in patients with, I think it was known pneumonia. And they found that, the 12-point scanning protocol was the one that had a 99% correlation with the accuracy of CT. But, sequentially down from that, you'd have like the 8-point, which might have been a 90%, and a 6-point, which might have been an 80-something%. So it really highlighted to me, I guess, the trade-off between accuracy and efficiency that you have to take. I don't think anybody in this meeting or anybody in an emergency department is really going to be interested in doing a 72-point lung scanning protocol because it's going to take way too much time. But just interesting to consider that 12 points was the sort of cutoff where they went, this has a very high degree of accuracy compared to CT scanning. And I think in terms of what those points were, if you look at the Volpicelli diagram up on the top of the screen, the only difference was it's including a posterior part of the chest. So 2 posterior scanning points. That was the only difference. All right, so just briefly, a couple of examples here. We've got A-lines. You can see that's the pleural line. I'm not sure if you can see my pointer on the screen, but pleural line, A-line, and then you can sort of make out a faded A-line at the bottom of the screen here. On the image on the right, that's taken with the curvilinear probe. You can see many more A-lines fading down there. And B-lines, here's just some example of B-lines, and we're going to go into what a B-line is and how it's developed in a moment, but just some examples of what multiple B-lines might look like. And something that I find helpful with the definition sort of really involving the fact that the B-line goes all the way to the bottom of the screen versus a Z-line, which doesn't, is to actually look at the bottom of the image and use the bottom of the image to actually define whether the B-lines are multiple or just a few, rather than looking at the pleural line itself, where you can sort of make out some individuals. But if you look at the bottom of the screen, you make sure that you're only seeing B-lines. So what is a B-line? Oh man, I can't tell you the rabbit hole I went down trying to understand how these things are formed and what their definition is. I've done a number of courses, online learning packages, and the variation in what people consider to be a B-line or not, sometimes it includes depth measurements. I had somebody tell me that it had to be more than 16 centimeters depth to even tell if it was a beeline or not. But the official 2012 International Consensus on Lung Ultrasound defined it as a discrete laser-like vertical hyperechoic reverberation artifact that arises from the pleural line, extends to the bottom of the screen without fading, and moves synchronously with lung sliding. Cut to 10 years later, and the 2022-2023 International Consensus on Lung Ultrasound said that definition is too subjective, and we need something more concrete to define what a beeline is. They noted that it was a subjective definition to call something laser-like, and that it goes to the bottom of the screen without fading. It's too subjective, and that counting the beelines in an intercostal space was not quantitative, but rather semi-quantitative at best, because depending on your angle of insonation, the probe that you're using, it really is quite challenging to say for sure how many beelines are in a particular intercostal space. And people end up just kind of going, oh, it's less, it's one or two, or it's multiple or confluent, rather than actually counting them. So why do beelines happen? And again, real rabbit hole. I read so many papers on this. They published these laboratory studies where they're trying to recreate the artifact to determine exactly how it happens. And there's just nothing definitive out there on exactly what it is. What we have is theories that make sort of physiological and anatomical sense. And so what I'm going to do is I'm just going to run through the two sort of more prevalent ones, and I'll be interested in everyone's thoughts on that at the end. But they make a good deal of sense, so hopefully it helps to understand. So sort of theory number one is you get this increased interstitial lung fluid from various causes, whether it's cardiogenic or pulmonary edema. You get this fluid overload in the interstitial space. Now, generally, our lymphatic system drains that fluid away, that excess fluid, but for whatever reason, it's overwhelmed because there's too much fluid. This causes a swelling of alveolar membranes and the interlobular septa. Remember that from earlier. And the swelling of the interlobular septa provides a tiny acoustic window into the lung. So if you think about your unbroken line of air in the lung, and then this tiny little interlobular septa swells because there's too much fluid in it, and that allows a window for the sound to get in. But because it's sort of interacting with these sort of air-water interfaces within the alveoli or around the alveoli, it bounces back and forth at high speed and causes this reverberation artifact, which is the beeline. So that's sort of theory explanation number one. Number two is you get sort of a localized damage from infection, ischemia, fibrosis, whatever it is, which causes a swelling of the alveolar membranes and interlobular septa. This swelling causes fluid then to spill over into the alveoli, which might be sort of blood or exudate, sometimes even including certain cells and stuff like that, which then continuously fills up the surrounding alveoli until a macroscopic visible volume is reached and sound is able to be transmitted through that sort of damaged area. And that's if it's located at the surface of the lung, which in 98%, roughly 95, 98% of times it is. And this leads to the same sort of mechanism where the sound now has an acoustic window to go in, and it interfaces with this fluid air interface, bouncing back and forth, creates the beeline. And this also, once it gets to a certain volume, this other theory is sort of similar to how consolidation is formed. And you might see that tissue-like echo texture once it progresses to a certain point. So now we sort of understand why, roughly, beelines exist. How do we evaluate them in patients. So I've sort of come up with 4 things that are important to the evaluation of B lines. First is, are they bilateral or are they focal? So bilateral B lines, let's just say we're using the blue protocol for instance here, and we've got 4 anterior points with multiple B lines. That paints a really strong picture of pulmonary edema. Whereas if you have B lines, multiple B lines in one intercostal space or on one lung but not the other, that paints more of a pneumonia picture. Is the distribution heterogeneous or homogeneous? And I had to look these words up, so don't feel bad. I put the definitions down at the bottom there for you. So heterogeneous being diverse in character or content, meaning that there's spared sections of lung, versus homogeneous where there's just B lines everywhere, there's no spared sections. So I'll show you some examples of what a spared section of lung might look like. But essentially that paints the picture of there's a specific area that is, is producing a lot of B lines. And then right next to that area, there's a section that's producing no B lines. And that indicates a sort of a non-pulmonary edema type of picture, whether it's from ischemia, trauma, infection. But those are just 2 things that you can sort of use to differentiate. Thirdly, there's which kind of probe you're going to use. Now, I don't think we talked about this yet, but again, this is one of those things where you get a lot of difference of opinion. Some people say, use the phased array because I'm going to also include the heart in my scan. And, that's fine. You can use a phased array. Phased array is good for differentiation of B lines, but it's not good for looking at the pleura, whereas the linear is really what you want to look at the pleura itself and any sort of subpleural consolidations, anything focused on the pleural line itself. You really want a linear probe. But you can also use a curvilinear probe for that. And I think if you're looking at pleural effusions or at the base of the lung, you really want a curvilinear probe as well. There was an interesting study done recently where they compared curvilinear versus phased array for detection of B lines and said that curvilinear was better. And it really, there's a couple of things as well in the 2023 consensus document that say that the frequency and the type of probe you use is actually really important to how many B lines you see. It does make a difference which probe you're using and what the frequency is. And they've determined that the curvilinear is better for identification of B lines. So there you have it. And then finally, how many B lines do you see? I think, again, as I discussed earlier, this is much more of a subjective thing than I think we'd like it to be. But generally speaking, you do there's maybe 1 B line there, not going to worry about that, versus, we've got quite a few B lines in this intercostal space, or we've got confluent B lines. So the whole intercostal space is just nothing but B line. So here's an example of just some scans I've taken myself of what I'd consider to be a homogeneous distribution of B lines. So you can see there's B lines all across the image there, and no sort of clear spared areas. And I couldn't get a great picture of a spared area from my own sort of image collection. So I just got one online. You can see in that left image there that you've sort of almost got, I wouldn't quite say that's an A line, but possibly there's an A line just about where that arrow is. And on either side of it, you can see pretty clearly confluent B lines. So what's the clinical relevance of this? I think, there's a number of causes for what we see with B lines, and that ranges from, interstitial syndrome is the kind of the throwaway term that we use, but cardiogenic pulmonary edema, pulmonary embolism can cause B lines, pneumonia can cause B lines, pulmonary fibrosis can cause B lines. But you can use those different methods of evaluation to differentiate that cause with a pretty good degree of accuracy in some studies. So for instance, if you have a bilateral diffuse homogeneous B lines with a regular pleural line and no consolidations, you can say pretty confidently that that's interstitial syndrome secondary to cardiogenic pulmonary edema. And if you add in a basic echo to look at LV function, that certainty increases even further. Whereas, you know, if you see focal B lines post a chest trauma at the site of pain, you can say quite confidently that that's going to be a pulmonary contusion. And, you know, if you've got an irregular pleural line with focal B lines, that's something that suggests quite strongly that there could be a pneumonia present. So moving on to pleural line abnormalities, there's really not a lot of evidence correlating different types of pleural line abnormalities with specific diagnoses. But there's sort of three things that we look at for the pleural line, excluding lung sliding for the moment. So I want to talk about thickened pleural line. And you could sort of see here, someone's tried to actually measure the pleural line. I don't know that there's a great deal of value in that. I think really you do sort of subjectively look at it and go, well, that looks quite thick and irregular versus actually getting your calipers out and measuring it. But the normal measurement for the pleural line is 0.2 to 0.3 millimeters. And thickening can indicate pulmonary fibrosis or sort of a chronic inflammation of the pleura from various causes. But often the thickening comes with irregularity, which we'll talk about in a moment. And that sort of indicates something different. So it's interesting to think about thickened pleural lines in isolation, whether there's, you know, asbestosis or, you know, some sort of calcified deposits along the pleura. It's really probably something that you wouldn't look at very specifically in a lot of cases. But anyway, let's move on to the thickened and broken pleural line abnormalities. So what I found really interesting, and we'll talk about this in a minute, that there's sort of this spectrum of consolidation. And if we go back to our sort of second definition of B lines there, when our alveoli start to fill with you know, pus or blood or whatever it is, the first sign of that can be an irregular or broken pleura. So it's often like the far left end of the spectrum of a consolidation. And it's some interesting terminology I came across was this idea of micro versus macro consolidations, which again, we'll talk about in a moment. And what I would consider this to be an example of a micro consolidation that's in contact with the pleural line, but hasn't developed to the point where we see our typical hypoechoic subpleural consolidation. So again, I've got some examples of those irregular and broken pleural lines in just a moment, but just quickly, including consolidation in the next section here. You can see there on the screen a really irregular hypoechoic area underneath the pleura. And this is with this really shredded border. And this is the shred sign that you hear people talk about. There's so many different signs and stuff in lung ultrasound, but really I think it's just helpful to think about it as a consolidation rather than a sign. So we talked about this. Fluid fills the alveoli, whether it's blood or pus, you get swelling of the membranes. The terminology that's used is really interesting. I think traditionally we talk about small, medium, large consolidations, but that again is really qualitative and it's not well defined in the literature what a consolidation of a certain size equals in terms of a diagnosis or correlation with CT. So there's been studies comparing lung ultrasound findings of consolidation with CT findings, but there really hasn't been enough work to say, oh, I've got a subpleural consolidation that's sub 1 centimeter. So it's like 0.8 centimeters or something like that. That equals a diagnosis of X. So that work hasn't been done. And that was one of the key findings of this 2022-2023 consensus, is that there needs to be further research in that area so that we can really focus in on what that means. But then you talk about, you go back to Lichtenstein and some of his work, and he very confidently says that if you have an anterior consolidation in an otherwise normal lung, that's highly sensitive and specific for pneumonia. So there's a lot of conflicting stuff out there, which is probably why it took me so long to put this all together. So I talked about this idea of micro versus macro consolidations, which is what they're proposing the new terminology is for lung ultrasound, and that we use these quantitative millimeter measurements to define the size of it and to correlate that with other findings. So the spectrum of consolidation sort of starts like this. You might get some B lines, some focal B lines with this irregular pleural line, irregular broken pleural line, and then that progresses to sort of this small subpleural consolidation, perhaps with a few B lines around the edges, and then to a more macro consolidation that's larger. It's got multiple lines extending from the base of it. It's possibly got some bronchograms and stuff in there. And I just really like this terminology for sort of categorizing these consolidations. So here's some examples. You can see on the screen on the left image that you've got like a really broken pleural line there with, what looks like a very small subpleural consolidation. And then this image on the right, you can see these irregularity in this pleural line and these tiny sort of breaks in it. I think what we're seeing there is the start of a more advanced consolidation. And, I often see these in sort of infective exacerbation of COPD patients. And I've sort of gone, oh, is that just a typical finding in that disease? Because that wouldn't surprise me with how damaged their lungs generally are. But actually what we're looking at here, we've got good lung sliding. I think it's actually the start of a consolidation rather than a chronic finding for that patient. Moving on to a more macro consolidation, this is the same image as before. It's the shred sign. It's larger. You can see a little bit of lung in the left side of the image there, and the rest of it is consolidation with some B lines heading down underneath. And in the image on the right, the more typical consolidation with air bronchograms and fluid-filled areas that we'd consider to be macro. So I've already kind of touched on this, but the literature really is a bit split on this. Whether some of it is more opinion-based and some of it is more science-based, I'm sure that there is that issue. But Lichtenstein and the work that he's done is very clear. Like, he's validated his studies, and he's said small anterior consolidations indicates a C profile in his blue protocol, which indicates a pneumonia in 95% of cases in the study that he did, which is pretty, it's pretty significant. But then the 2023 consensus statement says that the correlation between anterior subpleural consolidations and irregular pleura is not well understood and requires more research. So, I guess you've got to just take that all with a little bit of a pinch of salt. There's been systematic reviews and meta-analyses that said that these signs of consolidation are enough to diagnose pneumonia, but then these consensus statements say not so much. So still some work to be done. So some takeaways, I think still some ongoing research to ensure the diagnostic integrity of these findings, which I think can only be a good thing. But I don't think there's any denying that it's a highly useful tool in the out-of-hospital environment, especially where we don't have any other types of imaging we can do. And also for you guys, for differentiating the causes of respiratory distress. And I think if you really try and use those tools I've given you for evaluating B lines, you really can differentiate different causes. And I think that's very valuable. There's a lot of different protocols, and there has to be a balance between time and accuracy. There's no consensus on what protocol you should use or even what probe you should use. But I think the ones that I've presented to you today are probably a good starting point. And I really think that at its simplest, the blue protocol is one that we could all implement reasonably simply. The last thing I just wanted to mention, because I know being an ultrasound interest group, you all love reading about ultrasound in your spare time. I came across this book a couple of months ago, which I'm not sure if any of you have seen, called The POCUS Manifesto by Dr. Larry Israel. And he really presents an argument for why you should use POCUS for the evaluation of lungs, especially, but he does include other scanning areas as well. He presents it really well, presents the evidence, the sensitivity, specificities for individual exams really well. And I highly recommend it if you're looking for your next holiday read. There's about 50 more references than that, but I ran out of time. So thank you very much, everyone. And I see there's some questions in the chat, which I'll happily answer. John has just said, any advice on differentiating pneumonia, contusion, infarct in subpleural consolidations? John, I'd say a lot of it's based on other things than the lung ultrasound image itself. But certainly there's some stuff looking at pulmonary embolisms that they're quite well defined, some specific signs to look for there. But realistically, based purely on the size of it and stuff, it's hard to differentiate based just on that. You have to take into account the other signs. So like, for instance, if you're looking at, say, a COVID-19 lung, you know, where it's got B lines everywhere, and but they're non-homogeneous in nature, and you've got sort of smaller subpleural consolidations spread throughout the chest. You know, that pattern is quite specific for like an ARDS, whereas if you have an isolated consolidation in one area that's not really surrounded by a lot of B lines, and you're not finding any other areas of consolidation, you might consider something more like a pulmonary embolism or a contusion if there's a history of trauma. Anybody else got any questions? I like Kev's question about curvilinear in an abdominal setting is better, and the lung setting looks weird. I totally agree with you, Kev. My approach is to use the linear on a lung setting in the anterior zones, because I find the curvilinear in the lung setting is really grainy and hard to, I know all of the filtering and stuff's been taking off it because it's a lung preset, but I find it a lot easier to differentiate what I'm looking at with the linear probe. But they're saying quite clearly that the curvilinear is the one you want to use to evaluate B lines. So, and you know, there's something to be said for only using one probe for efficiency.